Yeah, good afternoon, everyone. It's really a huge pleasure for me to be invited for this Jano Club for global surgery. And as Ian really introduced, where my name is Dr. David Nirushwa, and the first question which started was like, how do you link your career with global surgery? And to start, today's presentation is really going to focus on the trend and the concerning trend of cesarean sections and its complex consequences of maternal health. And really this, I would say like this is where my journey started. So my journey started when I was finishing my medical school, and then I became a general practitioner, which is really the practice in Rwanda. So once you have the general medicine, not specialty, you are supposed among the scope of practice to be able to perform cesarean section, conduct normal deliveries, and do some other minor surgeries most of the time in one of rural hospitals. So when I was like the first time I was appointed in one of the district hospital, I remember we were like three doctors. At that time, no one really wanted to go to obstetric, not because we didn't love it, but because we were a little bit like threatened to really start delivering women, starting doing cesarean section. Then the random selection followed me. And when to follow me, like I really like discussed with my colleague, and we said, okay, I'm going there for 3 months. Then after 3 months, one of you will also have to rotate, and then the same and the same. And when I started really like in the labor ward, obstetric and gynecology department in one of the rural hospital where I was appointed in the East, I started getting exposed and really started learning about obstetric and gynecology and or surgery. I remember one of the first cases which has occurred, a woman who gave birth, and then after the delivery, the uterus came out, and everyone, the midwife and the family were much worried because the woman was breathing heavily, and also the midwife were looking for a doctor, and I was really like the one around. So at that time, they called me to come and help the woman. I was a little bit afraid, and I noticed that the woman was having uterine inversion, so like the uterus was outside. Again, I had never seen that case, but I knew about uterine inversion, and I could see the woman breathing and the family worried. So at that time, what I did, I just went aside and I looked at up to date, and I looked at how do we manage uterine inversion, and I noticed that there was really kind of nice drawing which was showing someone just pushing with the hand the uterus. And then I just came back, I pushed back, and at that time the uterus went back, the breathing stopped, and at that time I started getting much more interested. I started to like, oh, something which was quite very threatening now can be solved that easily. So similarly, I kept seeing some kind of women coming already either after transfer, having had like uterine rupture, and some of the time could reach the hospital without pass, already starting to lose consciousness. And then at that time, because I got more interested into that, I could mediate request, for example, to give IV fluid bolus, and at the same time feeling the pulse. And then I could see the pulse coming back, and could see the woman starting to talk to me. So all of those really becomes kind of early example, the early kind of cases that interested me more, to not fear cases involving surgery or involving complex or obstetric intervention. So at that time, I got the opportunity to do a kind of an online course, which was about sexual and reproductive health course, which was organized by WHO for 6 months to 1 year. And that one also opened the understanding about global women's health challenge, about cesarean section rate increase and the lack of access to cesarean section, and other women's health issues such as female sexual mutilation and so forth. So all of with that interest, and also getting exposed to some of the conditions such as obstetric fistula, I definitely got interested to become an OB/GYN or someone who is really dealing with some of those challenges. Because mostly main of the secret that I learned at that time was like to feel how, if you are there, if you can just document, and if you can really try to learn about the complication, really these are kind of surgical intervention. Once they are done, you are able to save the patient quickly, and you really see the changes happening. But if you're not there, if you can't do that, definitely you are more likely to lose the patient in front of you or just the woman. So similarly to cesarean section, the first exposure were like that, where we had women with placenta previa, and then you have started doing your cesarean section, but you don't know much exactly because maybe you have one few with your senior. But again, the secret was about now preparing, trying to say, like, if someone has placenta previa, where do you do your incision? Not really anticipating that you know everything, and having like in mind something like, how do I make sure that if I'm the one managing this woman, how do I make sure that I'm doing the best, I'm providing the best services anyone can also be able to give. And with that, I noticed that most of those interventions were feasible and they were making much changes. So this pushed me to decide to do a resident on obstetric and gynecology. And at that time, I had no doubt. After 1 year and around 8 months, I had no doubt about doing obstetric and gynecology. And the fear I had initially of just going to OB/GYN for 3 months ended that way. And I stayed there up to the time I did OB/GYN resident. So with the resident again and becoming a specialist on OB/GYN, working in a teaching hospital, this is where we started again now seeing some of the complicated cases coming from this hospital to our teaching hospital. And one of the lessons we've learned was like, if we remain, if we sit in our main teaching hospital and wait for complication to come, this is not going to work. And then we decided to start doing mentorship. And this mentorship, we're now focusing on like training younger doctors like I was a few years before, to make sure that complication can be prevented. So this is how I really like managed to enjoy, and then kept contributing at national and also at the global level. And this is how I'm finding myself really also being able to talk to all of you, to exchange with you about some challenges related to women's health and the global surgery. So I think that is a kind of a summary, and I would love now next to now focus on the main topic of today. And as you are seeing now, the main challenge we are going to focus on is the cesarean section. And we know that really like the trends are not quite very interesting, as we are going to see, and the methodology we are going to use as objective today, we really want to start by kind of update about maternal health status. Then we are going to use an interesting article which has been published in the British Medical Journal. And this is going to help us look at the global trend of cesarean section, but also look at the projection we have for the year 2030 if the current trends remain unchanged. Then we'll also have kind of a discussion related to cesarean section and their consequences on maternal health. Then after this, my colleague, Dr. Victor, will also come in to give example of Rwanda and how the cesarean section rate look like in our country. So if I start with a background, I always like, whenever I'm talking about a topic related to maternal health, I always wanted to focus on the causes. And the causes is not really, when you're talking about cesarean section, it's not only about the actual way we do intervention and the root cause, but I really like to go through the life course approach to women's health, because when we go back, and especially when you look at what happens in most of the countries, especially around middle-income countries, we notice that there is a complex of causes that we really need to look at. So when we look at the life course approach of women's health issues, in fact, some of the challenges started when the baby is in the utero, when a little fetus girl is in the utero, and sometimes challenges started occurring where in some areas there is kind of discrimination based on gender, and where there would be a preference to have a male baby. And when the baby is dead, there is born, there is this challenge sometime which is related to access to education. And some places, in some community, they are still privileging, in fact, the boy to be able to go to school rather than the girl, and especially because they expect the young girl to be able to have other responsibilities. So as the age increases, especially when the young girl reaches adolescent, so some other challenges start, such as access to contraception. These are really huge main challenges that occur. Then there are challenges related to abortion, like say young girl of just 15 years get pregnant now, like the solution, or there is a dilemma of whether the pregnancy has to be kept or not. And most of the time, these young girls do not know how to react. And most of the time they challenge the fact to even talk to their family, but also the community, and then they get abandoned. Then there are these early pregnancies. All of this, when you look at them, sometimes they have an impact on the cesarean section and the other maternal complications that sometimes we just focus on the end point, rather than also looking at this background background causes. Then there are sexual abuse, there are sexual mutilation in some societies where this remains a huge challenge. And then they have some other challenges that are also not well or much understood, showing that also really women's health just during the life course. We need to put more intervention, more research to make sure that we're addressing their issues. So when they get into the reproductive age, again, the domestic violence remain a huge challenge. Sexual and reproductive health right also plays a huge role. And this is related to even the either to conceive, to be pregnant, but also to be able to have access to the right mode of delivery, being either cesarean section or even normal spontaneous delivery, because some of the time the decision is taken by the husband or the decision is taken by the healthcare provider. So all of these are some of the challenge, again, which explain some of the things that we are going to be discussing. But also when they become really senior, when they become grandmothers, we know that there are some challenges such as menopause, such as osteoporosis, which are also in most of the society are not really kind of addressed. So showing that there is interconnection between some of the challenges that we are going to be looking at.
David, since we're a small group, can I interrupt you and ask a question? Since we're such a small group, can you go back to your prior slide?
All right.
Number 3 there, blames of delayed conception. Is that's pressure put upon the female to get pregnant? Is that what you mean by that?
Yes, yeah, definitely. This is happening most of the community when the couple have infertility. So immediately the assumption is that it's the woman, not the husband.
Not the husband.
And most of the time, it is just the woman who will just be coming to the hospital or even blamed by the families and so forth. Really, a lot of insults just occur to these women, and they really get a lot of challenges. That is what I want to mean. So thank you so much for
thank you for the clarification. Yeah, it's a very nice slide, David, by the way, doctor. It's a very nice.
All right. Yeah. So when you look at all of these within this background, you find out that some of these challenges that we are going to focus on, including the C-section, are interconnected. Then they end up by being some of the endpoints challenges that have other education issues, as you can see on this slide. So I can't also really focus on cesarean section without showing the main challenges that we are having related to maternal mortality. And as you can see, in 2020, we had around 800 women dying every day, and most of the time due to preventable causes related to pregnancy or childbirth. And this means that as I have started speaking, maybe 6 minutes now, around 3 women have already died as we speak. So showing that really maternal mortality remain a very huge issue. And we are going to see how cesarean section has an impact into this. And most of the maternal deaths, around 95%, in fact, occurs in low and middle income countries. And one of the main link is really lack to failure to access qualified healthcare providers into this region. So now if we go to C-section, cesarean section, which is the main topic for today, and probably the reason why we've chosen this journal club today to focus into this, as you know, cesarean section is a life-saving intervention. I can say equal to life-saving intervention, because when a woman is just pregnant, is just in labor and C-section cannot be done, sometimes the woman can have catastrophic consequences. So meaning that all women who are in labor should have access to cesarean section and timely and safe cesarean section if they need it. However, some of the studies or just some of the facts shows that a quarter of women who died, especially in low and middle income countries, had a death following cesarean section. So showing that even though it is this kind of life-saving intervention, we do have a lot of maternal mortality occurring following these interventions. So there is a kind of coexistence challenge where we have unmet need to cesarean section in some places, and then we have overuses of cesarean section. And this is really a huge global challenge. We people who are who are in the group surgery, which we really need to see how this can be tackled. And when we compare high and low middle income countries, they're quite interesting that in the low and middle income countries, the rate of death for cesarean section is around 50 to 100 times more compared to high income countries. So now we are going to look at one of really the article that I found quite interesting, which has gone into detail to show the rates and the trends of cesarean section. And as you can see on this picture, we are seeing some of the deaths due to cesarean section. And as you can see here, in most of the countries in Africa, the maternal mortality after cesarean section is above 10 per thousand. per 1,000 cesarean section, which is really high, meaning that among 100 women operated or having cesarean section, 1 woman and more is more likely to die due to complication of C-section. So this is really a huge and global challenge that really like also explain the reason why this journal or this article is quite interesting. So what article are we going to be discussing? So it's an article which is entitled Trend and Projection of Cesarean Section Rate, Global and Regional Estimates. It was published in the British Medical Journal Global Health. These are the authors, and as you can see the institution and mainly the UNFPA, UNICEF, UNDP, and World Bank. And then we have also the Ministry of Education, Shanghai Key Laboratory for Children. And these people have really done an amazing job and to look at really like the cesarean section rates and also the trend and the projection. So this article was published in May 2021, then it's really still relatively recent article. So how did they manage to get these trends and estimate and all of these? So they really used national data, and what helped them was the WHO states, member states countries, which are around 194 member states, and then they used important data sources such as demographic health surveys, and then they also use the health information system reports and the population-based health household survey definitely to be able to connect this data. Then with this, they managed to make estimation of trend by piecewise analysis of cesarean section at national, regional, and the global level. So why did they do this? The piecewise analysis. So they took from 1990 to 2018, but they looked at different intervals from 1990 to 2000, then from 2000 to 2010, then from 2010 to 2018. Then they were able to look at the cesarean section rate and then managed to look at the increase during that period, and then it allowed them to have idea about the trends. Then from those trends, if there is no change, they managed to make projection to see like how the cesarean section would be with in the next 6 years, which is the end of Sustainable Development Goals, at least the time we want to review the targets. So what were their key findings, which are quite interesting? In fact, when they gave data related to cesarean section, it was quite interesting because among 154 countries, which they managed to see the records, and this was representing 94% of world-derived births in 2018, they noticed that the global cesarean section rate at this time was 21.1, with average, in fact, which was quite very different because in some places the average was 8.2. This was mainly in the least developed countries, and then 24.2 in the less developed countries, and 27.2 in high-income countries. And you can see there is really a very huge difference, especially in the least developed country where the cesarean section rate is just 8.2, really much below the average. So when they went to sub-region, and when they did sub-region analysis, it was quite interesting because in sub-Saharan Africa, you can see this is even much terrible because they noticed that the cesarean section rate was just 5%. And we talk of this rate, we immediately understand how many women are not able to have access to cesarean section, to safe cesarean section when they need it, and what happens to them. So those resultant complications such as fistula, uterine rupture, and even maternal death. And as you can see, they had really very good data because this covered 88.6 birth coverage. So the highest rate, the other extreme was in the Latin America and the Caribbean, where they had when they had 42.8% of cesarean section rate. And this was representing 91.2 birth coverage in this region. And as you can again imagine, 42.8 is too much. When we look at the acceptable at risk cesarean section rate, which is around 10 to 15%, this is really way very high. So there are some countries which have even more extreme, such as the Dominican Republic, where they had 58%. And you can imagine, among two women who come for delivery, more than one will have a cesarean section. And then Brazil, they noticed that they had 55.7%, and then Cyprus 55, and then Egypt above 50 as well. So these countries, again, were really showing a high rate of cesarean section. And we are all afraid that probably this is where air countries might end up going if we don't really do kind of intervention. So what is another terrible scenario is about some countries which do not have access to C-section. So these are the countries, some of them in Africa and others in Latin America. And as you can see, Chad, for example, they noticed that at this time, the cesarean section was 1.4. Again, you can imagine how women are suffering. Countries such as Ethiopia, 1.9, Madagascar, 2%, and then Cameroon, 2.4, and then Haiti, 5.4, which is really too much low compared to what is needed. So this shows how much some women are much suffering because they can't access life-saving intervention, while other women are having much more than what they really need. So those was some observation related to the rate of cesarean section. So now they also tried to look at the trend, because as I said, they compare 1990 to 2018. And as you can see, they also had the very good data from around 190 countries, which covers 96.9% of live births worldwide. And they noticed that they've been increase of 19% from 1990 to 2018, again showing how probably we have been doing maybe non-medical indicated cesarean section, which sometimes can even end up by being harmful. There were some there's some places where the largest increase has been seen, like in developed countries, where like 22.9 was a kind of high increase, and then smallest in the least developed countries, which was 8.6. Again, these are the places where we feel like there is lack of access to cesarean section. There's some sub-region, again, where the increase was very high, such as Eastern Asia, Western Asia, and Northern Africa. And as you can see, they have 44.9, 34.7, and 31.5 percent point increase respectively. So this again show a crazy increase during that short time period, which is less than 20 years, 2 decades, to have such increase. Sub-Saharan Africa had the low, probably the low, and some of the lowest increase, which is 3.6%, and then in Northern America with 9.4. I think this is something for Northern America that would congratulate that. It was not that too much, but again, the cesarean section rate are also high, as we are going to see. When we compare these periods between 1990 and 2000, then 2000 and 2010 and 2018, the highest increase was between 2000 and 2010. And again, this is something that we need to look at and know exactly why this increase had happened. So those are some of the countries where, again, increase was over 50% during that whole period, such as China, Romania, Mauritius, Georgia, and Paraguay, where the increase was above 40%. So again, this shows that some countries, because it depends on country to countries, but some countries had even much, much higher, even though the global trends remain an issue. So with those findings about the cesarean section rate, which is really a huge challenge, and the trends that we've seen between 1990 and 2018, and now what would project in the 2030 if no intervention is done, now they have managed to do a kind of projection of cesarean section if nothing is done. Then they noticed that the global estimated increase is around 21% to 28%, with more than 38 million cesarean births in 2030. And as you can see, again, we are really more likely to be delivering 1 in 3 women by cesarean section. And this is really going to be a challenge. And as you can see, nearly 8% of this cesarean section will be conducted in less developing countries. Some of the reason being linked to the fertility rate within those countries, but also the number of women in reproductive health age. And this becomes even a bigger challenge, because this is where sometimes the facility, the healthcare providers are not even in a big number. So as you can see, again, another observation is that by 2030, there is a high risk that the cesarean section rate in a less developed country will be similar to developed country, and it will be around 36.6 in these countries, and then 36.5, which as you can see, there is no no differences. For risk developed countries, where we know that there is a kind of a huge challenge now, the cesarean section is projected to be around 11.8. So now, if we come, for example, to the continent of Africa and try to look what happens in Northern Africa, and as you remember, we talked about countries such as Egypt, which has cesarean section rate above 48%. In fact, they have two different challenge. The northern sub-region will surge to around 48.1%, while the sub-Saharan region will remain with the lowest rate at around 7.1%. And again, as you can see in 2030, in sub-Saharan Africa, women will not be able to have access to the cesarean section or to life-saving intervention that they need. These countries in this sub-region, especially in Asia by 2030, which is Eastern and Western Asia, the cesarean section rate might be at around 63 and 50% respectively. And again, meaning that 1 in 2 women, or more than 1 in 2 women, will be more likely to be delivered by cesarean section. And again, this really poses a huge challenge on the way we are managing women's, and the way we are preparing, and the way we are not allowing women to have the physiological changes that allow them to give birth naturally. This is the projection for America, where we have, again, Latin America and Caribbean, 54. And again, as you can see, in all sub-region that they've tried to look at, really like the trend are scary. And as you can see, they are going to reach around 1 in 2. This is definitely an unacceptable trend, similarly to Australia and New Zealand. If I put this into pictures, as you can see here, we have this trend, and as you can see in this article, they really tried to divide it into different categories. And this is the world, this is different regions. And as you can see, the solid lines show like the trend from 1990 to 2018. Then the dotted point showed like how the trend of cesarean section will just keep increasing up to 2030 if there is no intervention done, and probably lead to different complications. So how do we interpret some of these results from this article? There is no doubt that cesarean section have been increasing over the last 3 decades globally. And this is really a very huge challenge. And unfortunately, some part of the globe, such as sub-Saharan Africa, they have even a very small rate of cesarean section, like where we found that they have only 5%. So meaning that many women in this sub-region are not having access to this life-saving intervention, while like in some other places, they are being over-medicalized. Countries such as Latin America, Caribbean remain the highest in cesarean section. And then when you look at the global projection, we are more likely to have cesarean section rate of 30%. So this is 1 in 3 women having to be delivered by cesarean section. So sub-Saharan Africa will remain a challenge. And then we are afraid that in some places in Asia, such as Eastern Asia and Latin America, the mode of delivery, which is the most frequent or just the most common, is going to be cesarean section compared to vaginal delivery, which should really be the norm. So we have 2 different emergencies, which is a kind of a double burden in Africa, where some places there is over-medicalization with more cesarean section, where in sub-Saharan Africa, there is lack of access to intervention. Why do we think this increase is happening? What are some of the factors? How do we address them as the group surgery community? This is a huge challenge. Some are just due to ourselves as global healthcare providers. I remember I was listening to some women really giving testimony about not being given the opportunity to give delivery vaginally, being told that, this is very risky and we can't allow you unless you decide. But as a healthcare provider, as a qualified obstetrician, we feel like the best way to give birth is just by having a cesarean section, rather than being exposed to pain and also to risk, or by maybe your baby being obstructed and so forth. And this being told by healthcare providers. So these are some testimony of some of the women really bringing this as a huge challenge. So we need to change the brief. Then there is some other challenge such as remuneration, of course, which we can be sure but needs to be studied. There are convenience, sometime where we feel like cesarean section might be quicker than normal delivery. And then sometimes women and families will just come preferring to have cesarean section because of the tenants, because they are relative, because they know their family members have been delivered by C-section. But all of these have really some of the consequences which might be direct or long-term consequences to cesarean section. So why do we feel like this is really a global concern? It's because cesarean section, even though it's life-saving intervention, even though in some places with technology it might be safe, we know that this really is a very huge challenge in some other places, especially in low and middle-income countries, where they lack facilities and capability, and especially when it is the next cesarean section, this becomes a huge challenge. So some of the health complications include short-term and then long-term complications. And then if we don't do something, that is more likely to have more maternal and neonatal mortality due to cesarean section. This slide, which is almost one of the last slides I have, is really showing like the rates of complication once someone has had the cesarean section. So as you can see, for example, the placenta spectrum, placenta crater spectrum increases, especially when there is a placenta previa, up to the third cesarean section at around 40%. And this sometimes will happen in places where this woman who is having a risk of 40% because she's had 3 previous cesarean section, there is no qualified personnel, there is no multidisciplinary team to address this challenge, and this woman will die. These are some of the image. These are the really image of things that we sometimes faces into the practice. And as you can see, this woman has had cesarean section, developed peritonitis, developed surgical site wound infection. It took like 6 weeks just to cure because of complications which are associated by cesarean section. And then the second image is showing us again another image that we took really recently, and these are really image again where we have like a placenta in crater following multiple cesarean section, and this woman even ruptured before contraction starts. So most of the time, once these are happening, we can't even control the complication regardless of where women are. So you can understand these women will more likely lose their life. This is another woman whom we managed to save, whose life was saved by a brave younger doctor from like 3 hours distance, who noticed that this woman was having a bleeding, profuse bleeding after cesarean section due to placenta crater, and then put just a tourniquet using a Foley catheter to cramp the uterine vessels. And this woman reached to us after 3 hours and then managed to survive because this doctor has really managed to use some of the methods that really managed to save, to stop bleeding. But in some other condition, this woman would not be able to survive. And some of the time, we have really severe complications such as these, which are associated with infection. So we have bleeding, we have infection. All of these are possible complications in most of the places. So there are lots of implications for research where we need to really look at the long-term effect for women and children. With this trend, with this change of cesarean section, because they are there and there are a lot of things that we don't understanding. And then we need to look at these factors that influence over medicalization of birth. And then we need to address this triple burden, which is really lack of access, unmet need, but also overuse of cesarean section and unsafe access to cesarean section, especially where they're task shifting and so forth. And most of the time, probably not looking at the the complication. So these are some interventions which can be put in place to minimize the risk, such as preventing unnecessary primary cesarean section, quality antenatal care, clear scope of intervention when there is task shifting in places where non-physicians are just performing cesarean section, but teamwork in the theater also become quite very important. So these are some of the references that are used. Mainly one article that I really managed to go through, and I really again want to be thankful to these authors who did these wonderful articles. And then that is the other reference that was used. Thank you so much, and over to my colleague, Dr. Victor, just to give us an overview of what is happening to Rwanda, maybe before we have discussion. Thank you so much.
Thank you so much, Dr. Niyarushkwa. So we'll have Dr. Mivumbi present his talk next, and then we'll have questions and comments for you both. So Dr. Mivumbi, please feel free to share your screen.
Yeah, so can you see my screen?
Yes.
Okay, yeah, so thank you so much, Dr. David. Thank you so much, Ian and the team for organizing this and give us this opportunity to present and share some of the experience from our side. So yes, just briefly, because I think it been just a few minutes, as it has been said, I'm based in Rwanda. I work for DHPEGO, which is affiliated for Johns Hopkins and the national organization, which works in different country, for country, and then it's also working in Rwanda, supporting Ministry of Health in improving the maternal and newborn child health. And we do usually use a fund from the donor. The main donor is USAID, which is US Population Aid. So just briefly about my career pathway. So what makes me to really to embrace this career as a gynecologist? So I think when I completed my undergraduate, that was in 2005, I was appointed working in the district hospital, and that's district hospital was a very busy hospital. So because that time the delivery happening per year, it was 12,000 delivery per year, which means there it was 50 deliveries and 20 to 25 cesarean sections. So that time I was a GP, and I spent there 2 years. Then after I was very excited to do a master's obstetrics gynecologist because that exposure. Then later on, I was appointed to work at teaching hospital. And then late, I was appointed to work at the Ministry of Health. That was in 2012, 2013. And I was a maternal and newborn advisor to the Ministry of Health, Department of Maternal Child Health. And basically, I was leading the section which was maternal death review. And I have supported just to develop some of the guidelines, conducting this maternal death review across the country. Then later I joined programs working for JAPIGO. And initially I was the senior reproductive maternal health advisor. Then now I'm the deputy chief of party for that project. So usually my role is just providing strategic directions and support the Ministry of Health to develop some of the guidelines, policies, and also conduct some of advocacy. So based on that, I was very interested in the global surgery, basically on anatomy research section, because the time I was at the ministry, I remember reading this program for maternal death review. As every time, every month, I was getting some of the report from the district hospital because we established a committee at the hospital level, district hospital. So, and so I was the one who was analyzing maternal death review. And so then the main cause of maternal death, probably it's a postpartum hemorrhage. But we have started to see some of the new pattern whereby some of the unsafe cesarean section have been observed because in this review. And then I started establishing some of the program to support this performance of unsafe cesarean section because the main reason was linked to the poor knowledge for some of the healthcare professionals. So this has been said, cesarean section rate has increased worldwide over the last decade. So we have observed an increase globally, Africa and the other Latin American, Ocean, North American. And we do have some of the information evidence-based showing the reason why cesarean section is increasing. Some of the non-clinical factors are the changes in the characteristic of the population, such as the increasing obesity, multiple pregnancy in parents women. We do have also the increase due to waiting to determine how and when the child is born. We have also those patterns in Rwanda. And also physician factor, the fact that people do have a fear of medical litigation. We do have those cases as well in Rwanda. So this is the Rwanda health system. As you can see, we do have community health workers at the community level, health posts, and the health centers. So the cesarean section is being conducted at starting on medicalized health center and the above district hospital, level 2 teaching hospital, and the referral system. Those are a hospital and the facilities which provide a cesarean section. We call it comprehensive emergency obstetrical neonatal care. So the increase of cesarean section also has been observed over time in Rwanda. As you can see, this is an annual trend for cesarean section starting January 2017, March 2024, whereby you can see this very high increase of cesarean section until 2024. This is a number, this is a data from the Rwanda Health Management Information System report recently. As you can see, in 2017, the rate of cesarean section was 15.7%, but currently it's 23.3%. This is a countrywide an average, but you will find some of the district hospitals do have a high cesarean section, even roughly 40%. This is really something which is really easy to understand. And what we know cesarean section is intended to be life-saving intervention. However, this increase may reflect a lot of things because conducting cesarean section is one thing, and conducting self-cesarean section is another thing. So looking at some of the data from maternal death in Rwanda, this is coming from the MPDSR report. We have observed over 50% of maternal death happening. The model delivery, about 50% were cesarean section. All maternal death, over 50% delivery by cesarean section. And if we look at also based on the WHO classification of maternal death and causes among the 6 categories, we know the first contributing of maternal death is obstetrical hemorrhage, including, of course, postpartum hemorrhage, antepartum, intrapartum. But if we look at on this category of unanticipated complication of management, which is also contributing about 23%, if we dive deeper and looking at the underlying cause of this category, we can see that the complication due to obstetrical surgery, cesarean section, and procedure is very, very high. It's contributing to 82%. So meaning this increase of cesarean section might not be this life-saving intervention, but to another way around, which is very critical. And this is something which has been discussed across the country, putting together different data and the stakeholders in the ministry to analyze and those data and then come up with some of the strategy, because by analyzing this data, we have observed that the increase is really contributing to maternal death. And then this was also linked to the low skills for GP general practitioner, because according to the Rwanda law and the cesarean section has to be conducted by general practitioners and obstetricians. And we have observed that probably after many analyses, probably in pre-service education, probably there is an issue and you have to explore. So based on those data, so together Ministry of Health and the different stakeholders has already started to initiate some of the initiative to be able to mitigate these issues, whereby in collaboration with the Rwanda Society of Obstetrics and Gyne, have started conducting mentorship. Obstetrician gynecologists going on the ground on the district hospital and spending more time with the general practitioner young graduates, and then try to transfer some of the skills. Also, in collaboration with Japaigo and the other stakeholders, there is also an initiative of introduction of the Robinson classification. This is a WHO tool which helps to really do an audit of cesarean section, to know the rate, to know the reason, the indication, and then leverage if the current cesarean section is saving. So it helps the hospital to see the trend and then recognize the right cesarean section and indication. Also, there is another program which is being implemented countrywide to enhance pre-service education in collaboration with a University of Rwanda and the Ministry of Health and the different partners, really to strengthen the education, and then a young graduate can get really enough skills so that they can go on the ground. Because of the shortage of staff in this country, so if a young graduate is already graduated and assigned in the hospital, immediately he has to start to conduct all activities, including cesarean section. So if they are not well trained, this is really very critical. So that's what I want just to share with you as a case of Rwanda, showing that the fact that the cesarean section is increasing, it doesn't mean it's a life-saving intervention. It could be also harmful. And then that's what we have observed. And then currently there is an ongoing discussion for mitigate this issue. So thank you so much for your attention. And I appreciate again being in this conversation and ready to respond some of the question, clarification, and then hear a comment from you. Thank you.
Yeah, so I'd really like to thank you both for sharing your stories with us. Your presentations definitely made us more sensitive to the diverse issues surrounding C-sections, C-section rates, and maternal care. There was lots of great information there. So does anyone want to ask a question or share a comment?
This is so good. Thank you so much, both of you. I have so many questions. It's such a good topic. I think this is really an important topic, at least in the global surgery world. I'm interested. Victor had one slide he put up about the causes of this. It's really, how much of it do you think has to do with provider comfortableness? This is a constant discussion in the American system because, you know, we are seeing a lot higher C-section rates here also. And it's driven somewhat by maternal health, but also by maternal preference. And because of all the complications and untoward events from having a vaginal delivery. But it's your sense, at least from Victor's slide, that it's really multifactorial in your part of the world. Would you agree?
I beg your pardon? So
is it really caused by multiple things in your part of the world, or you think there's one overwhelming reason why the C-section rate has gone up so much?
Yeah, exactly. Yeah, you're right, because we do have a multiple reason for this increase. As you say, sometimes it's due to maternal interest, maternal request, but also another point is fear of mitigation as well.
Mm-hmm.
And those have been observed as well. And then we do have some of data whereby we have observed the high increase in private clinics compared to public as well. And the other point also is lack of and the insufficient knowledge for decision making for some of the healthcare providers, and then they can rush by deciding in the cesarean section instead of maybe waiting because of lack of the knowledge as well. So it's a multiple reason, as you said. Thanks.
Mm-hmm. Maybe Victor, something that I also wanted to add on that is I think it's like a vicious circle, because most of the cases are now previous cesarean sections. So once the primary C-section is not prevented, where there is this maternal request and so many others. So most of the time, the woman will end up by having again a cesarean section once one was done. We know trial rape after C-section is really something that we are again encouraging, but previous cesarean section also remained one of the main challenge there.
Samson, go ahead.
Yeah, I'd like to introduce, I'd like to preface my question by letting you all know that I'm an engineer and not a clinician. But I try to take these things apart and try to figure out what would be the good engineering project to start off with. So I have two questions. You all have identified at least 4 major pain points. So just with the information that the Rwandan team has, I'd like to know what you think is the most important pain point to address. So the number one is the skill of the healthcare worker, which includes knowledge of the patient, but as well as their actual training. I'm interested in knowing, are you more interested in improving the outcomes of cesarean sections as compared to reducing the number of cesarean sections? And number 3, do you need a prospective decision tool, not a retrospective classification tool like the Robinson tool? In other words, is it important to you to get the right woman to the cesarean section? So as for those 3 questions, which of those are the most important to moving forward? A decision tool, a better outcome for the cesarean section, or the skills for the healthcare worker?
Yeah, maybe I can first respond what I think probably correct will come in. Yeah, the important thing is to improve the outcome because
Of the cesarean section.
The outcome of the cesarean section, because the rate, it doesn't really mean a lot, but the outcome.
Yeah, may I then do a corollary? So the cesarean section rate is not really the metric of interest, then, is it? The metric of interest is outcomes or changes in outcome. Is
Yes.
it? Would you agree? Okay.
Yeah, definitely.
Well, how about the other things? Like, for example, a decision tool prospectively. In other words, are there deterministic clinical and other types of markers that could tell you whether a woman should have a cesarean section or not?
Yeah,
Do you
so
think
this
that's
is a kind of
deterministic?
yeah. So go ahead. Go ahead.
Yeah, it's just, I know these are heuristic and it's not, it's the way I think about things. But what are your thoughts? Is it even
Yeah,
a
so
fair question?
maybe if I can maybe explain well and make me understanding. So one intervention wouldn't be enough just to address these issues, but the goal is to improve the outcome of cesarean section, the outcome of the woman, because cesarean section is intended to save the life, because the normal delivery, it's not possible, then we go for a life-saving intervention. However, we have observed some of the weaknesses for some of the healthcare providers. Therefore, some of them, they don't know what is happening. So they needed to retrospective tools to review and learn from what happened to improve. But again, because we know the reason why some of the outcome are not good, the reason are linked to the knowledge. We also want also to come in with the training, because that gap is there. We really recognize that gap, and then we know the reason. We have observed, we know the reason why some of the young graduates are not really performing the cesarean section well. It's because they have been not yet exposed. They didn't really gain the knowledge. Therefore, we need to focus on individual and then provide those skills. But again, if we see the increase of cesarean section, is it a good thing, or there is a bad outcome from there? So we need also to review using some of the tools like Robinson classification to see the current category of cesarean section which are being provided, if are really in good norms. So to know that even though my hospital, there is increase, but the outcome is good. So that's what maybe I can explain. But both are related and linked, but the end product is improvement of the women who underwent cesarean section.
Okay, thank you so much.
Instead of the other way around. Yeah. I don't know if you get me.
Yeah, I don't want to keep having a one-on-one discussion, but I'm new to the question, so I'll be thinking about it. But I do want to just say that there's a difference between the Robinson classification tool and a predictive tool that could be developed that could help the decision before, so it can help guide the well-trained healthcare worker. So anyways, these are the things that would be great projects to
think about.
work on. Yeah.
So maybe I think what I would really like quickly add is, different countries have different needs, especially based on the rate of cesarean section. And as we've seen, if you look at a country such as, which has like cesarean section, which is around 2%. So this country really have a lot of women who do not have access to cesarean section. So the need there is to have a human resource to train people, to train more people who can really provide the cesarean section. So the human resource is the main challenge. So if you now look at the other countries which are at extreme, so you've seen countries which are at around 50% cesarean section rate, and this one really have much more of a challenge where they need to improve the intrapartum care, because this is where people have moved from allowing women to have normal physiology of childbirth, which should really take place, and still everyone moved to cesarean section. And this is a kind of a complex thing where we have to make sure that we are providing respectful childbirth care, where the woman is laid at the center, where the pain management is provided, all of the things which make the woman fear to really be able to have a normal delivery. So at this point, as you are saying, we need to have a kind of like, how do we decide to provide a C-section? So there are some other categories of countries like Rwanda, which are just in between, or which are a little bit higher in access to cesarean section. So the positive things, at least women are able to have access to cesarean section, which is when they need it. But the negative point is like some of those women who have access to that C-section might have unsafe cesarean section or unnecessary, which can be a kind of a combination. So at that point, you look at solution based really like on those rates, and probably need to really do a kind of multivariate analysis to know what is the main challenge based on the rate.
But is this team interested in that multivariate analysis? I mean, at least in the context of Rwanda.
Definitely, yes.
Yeah, this seems like a great project for some master's students.
Yeah, those were great discussion points raised. Thank you. So we have time for one more question, so I'll ask this. This is something I'm just curious about. Either of you could answer. So if a woman has had a C-section already, what are the key considerations for a woman when deciding between a repeat C-section for her next child or attempting a vaginal birth?
Yeah, I think that is kind of a very interesting question, because as you said, it's a kind of vicious cycle. So if you are not preventing the primary cesarean section, we are more likely to have more people coming with one previous cesarean section, two previous cesarean section, and even three, and then they end up increasing the overall rate of C-section. And even when they are doing projection, when in a population you have like maybe 20% of the population having had cesarean section, and the fertility rate is still at around 4, you will know that those women will definitely come back, and when they come back, they are more likely to have other C-section. So the projection becomes even higher than what had happened a few years before you had that higher rate of the primary C-section. So some of the considerations are required are also clear, and they will depend on the health facility. So if you're like in a health facility where you have, for example, you're in a teaching hospital such as John Hopkins, or even our hospital here in a teaching hospital where you have resident, you have intern, you have medical student, you have midwife, you have everyone who is able to follow this woman, able to put the woman on a CTG. And at the time when there is a need for emergency cesarean section, for example, if uterine rupture is pending or that is occurring, then you know that within like 10 minutes, the baby is already born. So you are more likely to allow the woman definitely to try labor after having cesarean section. And of course, there are some of the criteria which increase the success rate, and education and counseling is very key. So if a woman has had previous cesarean section and maybe has had normal vaginal delivery, this woman is more likely to have C-section. If the labor is spontaneous but the education the woman has had during the antenatal care become really the key, so that she really does understand all of those factors, understand the success rate, which would be between 60 and 80, based on some of all other factors, such as the previous indication, whether the woman is in labor, or whether definitely the woman has had a normal deliveries. So those being discussed, those are like more mainly medical, but the facility, the capability of the facility to be able to monitor the woman is also key, because we know the uterine rupture risk is around 0.6, 0.8, which is low. But again, because it is there and it's more than someone who has not had a cesarean section, we need to be able to really do all of that. So the health facility becomes a very important determinant, but also the woman and the healthcare provider.
Thank you for answering my question. That's really helpful. Okay, so I'd like to end off the session by thanking Dr. Nirushkwa and Dr. Mibumbi for leading tonight's conversation. You've really enlightened us with your expertise and insightful perspectives on C-section rates and maternal health. And we're very happy that we were able to hear about this topic today. It's definitely a complex one, as we've learned. So this will be a great resource for us to post and share with others. Thank you so much for your time.
Thank you.
Thank you. It was a pleasure really to be part.
Yeah.
Thank you.
Thank
Bye.
you, everyone. Bye-bye.